Yeah,
We are live, sir.
yeah, great. Good evening, friends. Welcome to Indian Arthroscopy Society webinar today. We have a very interesting topic and a very interesting speaker today, Dr. Med Christoph Kukos. He's essentially a Greek guy practicing from long years now in Germany. He's going to talk about arthroscopic subscapular augmentation, a very interesting topic, and I think a lot of us who are into shoulder arthroscopy would be interesting to learn and understand what he wants to tell us with this uh, presentation. I welcome Dr. Samantha, Secretary of the Indian Arthroscopy Society, and at the outset would thank Dr. K. Karthik Raj for arranging this wonderful webinar for Indian Arthroscopy Society. Samantha, if you can just kindly
Yes, this
start.
is a great honor. Actually, my regards to my president, Dr. IPS sir, and also my colleagues, Sandeep, and also Rajiv is there, and also my high regards to Dr. Christos. So he's going to tell us about the ASA because most of the people now, those who are doing the arthroscopic subscapulary advancement, most of the people still they don't believe in that. They talk of the internal restriction and all that. Probably we are going to listen from the master, and I welcome you, sir. Thank you for acknowledging our invitation. I think we can go ahead with the scientific thing. Thank you all.
Thank you, Samantha. Karthik, if you can kindly introduce our guest speaker today to all our members of Indian Arthroscopy Society.
Thank you, IPS, sir. Thanking you for allowing me to part of this webinar. Dr. Christos, I do not think he requires an introduction. Everyone knows him. And at first, thank you, Dr. Christos, for accepting our invitation. So he is the head of the arthroscopic department in Germany, Metman Hospital, and he does into subspecialties, especially involving the elbow, shoulder, and an excellent arthroscopic surgeon. So the topic of today will be on arthroscopic subscapularis augmentation, which is highly a debated one, and there are a lot of pros and cons. I think it's better to listen from the maestro himself. So I'll pass on it to Dr. Christos to start with the talk.
Thank you from my side very, very much for the invitation. I'm really honored to be here. I'm going to share my screen at the same time. I hope you can see everything.
Yeah, we can see it.
Thank you.
So, as we said, I'm going to talk about the arthroscopic subscapularis augmentation. And the question is it a revolution or is it something that is coming from the past? My disclosures actually have nothing to do with this topic. If we go through the literature and we see the redislocation rates generally, especially in the adolescents, if we see the patients that are being treated non-operatively, we see a redislocation rate of 48 to 100%, and that depends, of course, on studies that we actually see. But at the same time, if we go ahead and especially now there is a recent study from 2019 where they studied the redislocation rate, the recurrence rate after a Bankert repair in the adolescent patients, we see that's 33.3. That's quite high, and that's why we have to think about something else on top of that. Even Castagna in 2012, in his cases, he found out that he had a 21% recurrence rate after his Bankert repairs. And again, if we go and see the patients, they actually do or are engaged in contact sports, there's a redislocation or recurrence rate after a Bankert repair. If you see the first one in the list is in rugby, then American football, and of course other contact sports. That means that the Bankert repair is not enough. So the factors that actually affect, or the factors that we actually take into consideration before we go ahead and we do a special stabilization method is, of course, the anterior and the anterior inferior capsule with labrum, the bone glenoid defect, and the Hill-Sachs defect. So, because we're not going to talk about the bony procedures, lateral Z or a bone block. So we need to have, especially for this amount of patients, for this 33% of recurrence rate, some augmentation soft tissue techniques. The ones that we have is, of course, as we all know, remplissage. That's from Eugene Wolf. The ASA, that's the one that we are talking about today. And the dynamic anterior stabilization, the one being described from Latterman from Switzerland. So what's the ASA? What's the arthroscopic subscapularis augmentation? It's a tenodesis of the upper part of the subscapularis tendon as an augmentation technique on top with a Bankart repair. That comes on top. It's an augmentation, a supplementing method. And if we just look at it and compare it with remplissage, like just in a common sense, we don't need to go into a biomechanical analysis. Just look at the picture on the left side. ASA pushes the humeral head posteriorly to the back, and whereas the remplissage pulls the humeral head to the back. So just in common sense, but just by letting us use our common sense, like just pushing something is much better or more stable than actually pulling something. So ASA is a dynamic stabilization. It's, of course, non-anatomic. It's supporting, supplementing. It's an easy technique. So where it all started, it was back in 1986. First, the Lenny Johnson himself said that every stabilization method that after anterior shoulder dislocation has to include the subscap tendon. So what he did is he did a series of patients by just fixing the subscap tendon by using those some metal staples. But these metal staples actually caused arthritis, and that's why he afterwards he actually abandoned this technique. So we come now to 2013, where Professor Maiotti came up and he said, okay, why not doing this technique again with all the materials that we have nowadays, with all these soft tissue anchors, these knotless anchors that we have? They're not going to cause this arthritis, what the metal staples actually caused back in 1986. What's the role of the subscapularis tendon, though? So even in the Bristow procedure is described when you bring through the subscap tendon, your conjoint tendon together with your coracoid, that prevents the subscap tendon to move upwards when you actually raise your arm. That's the sling effect, what the Boileau actually describes in the Larazé procedure. On top of that, a fellow man, a guy that Professor Simeonidis in 1972, a Greek guy, he did a cadaveric study, and he found out that every anterior shoulder dislocation, we have an elongation of the subscap tendon. And if you see the pictures, if we just do a Bankart repair, we don't really restore the elongation of the subscapularis tendon there. So a recent study that it was done in Béguet in Tübingen, of course, with help of Professor Maiotti, a biomechanical study. What was done there, they had 8 cadaver shoulders, And what they did, they measured the glenohumeral translation in 0, 30, and 60 degrees of abduction after, of course, everything in the maximal external rotation by putting a 30 Newton load on the humerus. All these cadaveric shoulders had a Bankart lesion and a bony Bankart lesion with an anterior bone defect 15 to 20%. And what they did there was the ASA plus, of course, the Bankart repair. And what they found out is that the ASA actually decreased the glenohumeral translation. What they also found, and I want you to actually keep it in mind because afterwards I'm going to mention it in the indications, they found a decrease in the limitation of external rotation in the 60-degree position of abduction. So why is subscap, as we mentioned, really important, and why that not moving upwards helps? Because that actually helps, protects, and strengthens the coracohumeral ligament. And as we all know, the coracohumeral ligament is the main static stabilizer of the shoulder, especially from the superior to inferior direction, and with the shoulder in the external rotation. So by just using the ASA technique, by just fixing the subscap tendon, we protect and we strengthen our coracohumeral ligament. So we don't allow the humeral head of translating, of going to the front and to or anterior-inferiorly. So a clinical study was done by Maiori himself with his partner, Raffaele Russo, where they operated on 89 patients, all of them engaged in sports, and all of them had an anterior instability with both glenoid bone loss and Ilzak's lesion. The mean follow-up was 31.5 months. And after this follow-up, they had just 3.4% redislocation rate. That means just 3 post-traumatic redislocations. And the theory, or maybe our thoughts that the ASA may cause an external rotation deficit, actually was not the case here, because here they had an external rotation deficit of 6 degrees with the arm in 0 degrees, and 3 degrees in 9 degrees of abduction. They went a bit further, and they actually compared the ASA to Larrazé in cases where they had moderate glenoid bone loss. So they had 2 groups of 20 individuals where they operated on. The mean follow-up was 21 months. And in these both techniques, they had no complication rates. There was no complication whatsoever in both techniques, even no recurrence, no redislocation. And even though that there was no statistical difference, if you see the external rotation deficit in the Larrazé group was a bit more, 9 degrees, whereas in the ASA group was just 8 degrees. And we have another recent study from colleagues from China, where they actually said exactly the same thing, that the ASA is a safe and a reliable method without having any problems with external rotation. Another study, so the Athenian or the Athens experience, and here I have to thank Manos Brilakis for giving me the data, because these data has not been published because they're waiting for the 5-year results. And what they did there, they had 25 patients with Bankert and ASA. And if you see, they even actually combined the techniques with remplissage in 3 patients. And of course, in huge bone glenoid losses, they use a bone block with ASA as well, or all these techniques together. The mean follow-up was 20 months. As I said, they were waiting for the 5-year results, and then they're going to publish it. And the rate dislocation rate was just 5%. And not just that, you see that the functional scores preoperatively and postoperatively are much, much better. They were much better postoperatively. So what are the indications for this ASA technique? Of course, a capsular labral deficiency when we don't have enough capsule or enough labrum there. A glenoid bone loss less than 20%. Contact sports, the problem with the Bankert repair, as we mentioned in the beginning. Hill-Sachs defects, maybe as an alternative to remplissage, or sometimes as a combination to remplissage. Hyperlax patients, and of course, even in failed Bankert repairs. The contraindications, of course, glenoid bone defect more than 20%, where we have to do a bony procedure, but we can combine the bony procedure with ASA, what Professor Taverna does as well, and osteoarthritis. Why? Because there were some studies that showed that it causes osteoarthritis in the front, even though the Professor Mayari is actually he's going to publish that, but he has shown some cases where so patients that already had arthritis didn't actually have any more after they had this ASA procedure. And a relative contraindication is what I told you before to keep in mind, is the throwing athletes, cause in the cadaveric studies, they found out there's a decrease in the external rotation limitation in the 60 degrees of abduction. So how do we do this technique? You can do a lateral decubitus, that's what I do, or you can do a beach chair, it doesn't matter. You have to have the arm in 40 degrees of abduction and 15 degrees forward flexion. You can use a standard arthroscope, you don't need a 70 degree arthroscope. And the portals that you have to use here is the anterior posterior, and an accessory anterolateral portal just for shuttling of the sutures. If you want to use cannulas, you can use, of course, cannulas. I don't use any cannulas generally, even for rotator cuff pathologies, but of course you can use them. So what you do your normal Bankert repair as you always do it. And then on top of that, you have to penetrate the upper third of the subscap tendon. You pass labral tape. You can use any tape. I use a labral tape. Professor Mayari uses actually a fiber tape. I find it too thick, too aggressive actually from this region of the body. And you do a lasso loop configuration because it's much stronger. So you load your 3.5 knotless peak anchor with your labral tape, and you actually tap in 3 or 9 o'clock position, depends on what side you operate on. And of course, by just putting some traction on your suture tape, you insert your anchor. Here's the video with this technique. As I said, you just do your Bankert repair. As you see here, you can use knotless or maybe normal anchors as well. I shuttle my sutures with a 45 degree suture lasso, as we always do. And then on top of that, after I'm done, I penetrate the subscap tendon. This video goes back and forth, as I see here. here is, I'm going to put it a bit back. Yeah, it's the lasso loop configuration. Have you seen in the upper third? And then you drill and you just have to bring your anchor. In this case, it's the left shoulder. That means a 9 o'clock position. You just have to bring your anchor as you see here. And after that, you're going to see how solid this whole construct is. And you just step your anchor as you see. And this is a subscap tendon that you see here on the video. So, and that was it. You just have to cut the sutures flush as you do it always with your Bankert repair. So here's another patient. This patient actually was having shoulder dislocations for 13 years, and like at least 5 till 6 times a day, because she she got her kids and she didn't want to be operated on. And as you see here, there's this cartilage loss in the front, but what she also sees is the anterior migration of the humeral head. She didn't have any bony lesions, no Hill-Sachs defects. It was weird, but she didn't have any, even though that she had this problem like for 13 years. And then you see the subscap here after the ASA. And after we've done this whole the ASA technique, you see the solid construct and you see the reduction of the whole humeral head, how it goes to the back. And even I myself, I try every time to push the shoulder, to push the humeral head to the front, and it doesn't go to the front after this ASA procedure. It doesn't go at all. Like you can try, if you do it, try it. It's not going to go to the front. So the aftercare, what I actually do, it's the same procedure after a Bankert repair. I put him 3 weeks in a sling. No external rotation is allowed for these 3 weeks. And then after that, like after these 3 weeks, they are allowed to have external rotation to 0 degrees, the neutral position, for 6 weeks overall. And then after these 6 weeks, we remove the sling and we actually start with active motion. No full bearing for 3 months. And return to contact sports, I am a bit defensive here. And after 7 months, in comparison to other colleagues or to Professor Maiotti, where he actually lets them return to sport after 4 months. So you're going to see video of him from him in a bit. So this is a picture from the Athens group. I have to thank again the Manus Brulakis because I haven't taken any photos of my patients. And you see here, the right shoulder is 3 months after remplissage, and the left shoulder is 14 months after ASA. And you see there's not such a big of a difference between these two groups, like in the ASA and then remplissage. And even this 5 degrees of maybe an external rotation that the patient may lose, they can't feel it, they don't see it. And here, just to show and thank Professor Maiotti for giving me this video. This is a patient that he is a skydiver, a champion actually of the Italian skydiving team. He had, after skydiving, an anterior shoulder dislocation. He was operated and he had this ASA procedure. And this is the video, like about 5 months after the ASA procedure, where he won the bronze medal in the World Cup skydiving in Bahrain in 2015. My experience from June 2019, I've done 16 patients, and then my indications is much more aggressive towards ASA, has been more aggressive towards ASA, because I've seen that they have no problem with this external rotation. Till now, I haven't had any dislocation. Of course, it's short term, but I haven't had any dislocation. And I had just a case. It was a guy that had a serious bicycle accident with the car 8 weeks after the operation, and he didn't have any dislocation. Not just that, he didn't have any apprehension at all, even though he fell on his extended arm, and Gauge test was negative as well. So in conclusion, the ASA is a really effective technique for recurrent shoulder dislocations, even in patients with Hill-Sachs lesions, or with patients that have a moderate anterior glenoid bone loss, not more than 20%. So we don't have to over indicate the Latarze or the bony procedure, the bone block procedure. It's important for capsular deficiency in patients engaged in contact sports or hyperlax patients. And most of all, it's a safe and it's an easy technique where you need almost no learning curve, and it doesn't have so many complications in comparison to, for example, remplissage or to any other bony procedures, Latarze or bone block. I have to thank you for your attention, and because, as you said, I'm Greek, so I invite you into the shoulder course, the 5th Athens shoulder course 2022, and in February, because 21, as we all know, with this COVID situation, we can't actually organize anything. So for 2022, thank you very much.
Thank you, Dr. Christos, for this wonderful talk. It was really enchanting, a lot of new things. I think everyone listening would have a mind a little bit onto ASA from Bankarts already now. It's really interesting on that. Dr. Christos, can we start the question session? Just having you some questions.
Of course.
One question of mine, as you told me, you're now started to move on more and more towards the ASA from the bank cards. So what is your line of discrimination in patient selection from isolated bank cards towards combination with ASA? That is my question number one. Question number two, now there are these kind of patients where the labral quality is not good, especially with multiple times, hardly any labrum, but they do not have much of a bone loss. Now, in these cases, we normally tend to go for a bony block or a dynamic bony, like a Latarze. Now, because repairing the labrum makes no sense. It's just a flimsy band of tissue. Now, can you, because I've seen some patients of Professor Marco being done. So what is your take on doing an isolated ASA without repairing the bank cards? An isolated ASA without repairing the bank cards in that case?
I always combine both of them. Even if I don't have any labrum, I'm going to take as much capsule as I can. Always. Like I always try to do a shift, so I'm to bring this kind of a bridge that we have here, this bulky thing. And as you said, even in these labral deficiencies where we don't see the labrum, it doesn't matter if we don't have the labrum. And I think at the end of the day that even when you do your bankage repair, I don't really believe that the labrum is the one that stabilizes the whole thing. It's the capsule that stabilizes the whole thing. You try to reduce the volume of the capsule, and that's the thing. That's the problem. So, and I go towards the ASA because first I can sleep better. So I don't really do any bankard alone anymore. That's my indication. And especially in adults, especially in so patients, they are 20, but till the age of 25, they are all of them are hyperlax. So especially in these patients, they are the best candidates because they are going to be back into your office not in 2 years or 3 years, they're going to be in 1 year. Because as we all know, especially here in Germany, they all do sport. All people do sports here in comparison to Greece, for example, where they, after some period of time, they don't do anything. But here in Germany, they are active. So they're going to come back after a year with a dislocated shoulder. So as I said, I want to sleep well. So I'm going to do the ASA as well, because it's not going to cause any other problems.
Perfect. Thank you. Hi, Roshan sir. Welcome. Do you have any questions, Roshan?
Hi. Thanks, Christos. That was a wonderful talk. In fact, I heard this talk many times from Manos as well as Stephen Schroeter, who have been marketing this technique for many years now. But I always had some questions regarding the use of subscapularis, because I feel subscap is a very, very dynamic muscle of the shoulder joint and biomechanically very, very important, because if you see the footprint of subscapularis on the humeral head is significantly high, and it controls not only the stabilizing function, but the other functions also. So I had a few questions related to augmentation of subscap. I have done these cases, this type of augmentation for epileptic patient, the patient who has got uncontrolled convulsions and they have a recurrent dislocation where you have very less options. I've done few these cases in the neglected anterior dislocation cases where I had done an open repair, open relocation of the shoulder joint, where I had done the subscapularis augmentation to get more and more stability. But doing arthroscopic procedure, this is very important, because doing arthroscopic, I don't think so you come to know what exactly is the length at which your rotations are going to get restricted. Because I've seen this been operated at many places during the live surgery in Athens last year's Athens shoulder course. Even in our arthroscopy academy, we had a live surgery on this ASA procedure. And what I realized the problem is the understanding the at what position of the shoulder joint you want to stabilize the subscapularis tendon, because this is a tenodesis effect. So can you elaborate more? Because the cadaveric study shows that 0, 30 and 60 degree, you have no problem with stability with subscapularis. But in practical reason, the biomechanics of the shoulder joint is going to change in toto. And I may feel this may lead to early osteoarthritis of shoulder, which is very common and evident after every Bankart surgery, because nowadays we are seeing a lot of early arthritis in the glenohumeral joint, especially for after the Bankart surgery. So can you enlighten more on the position of the shoulder joint at what you will like to have the fixed length of the subscapularis inside of the joint?
So yes, thank you for the questions. Really good one. And remember, I think you asked that in the Athens shoulder course as well, in February.
Yes.
And what Manos does is he puts it in the max external rotation. I don't do that. I do it exactly as Maiori actually does it. I do it in neutral position. In the beginning, I've tried a couple by doing the external rotation, but I think I was kind of risking my Bankart repair. And I haven't seen any difference in the ones that where I put it in external rotation, in max external rotation, in the neutral position. Now I do it just in neutral position because I don't see any difference. And the biomechanics, how it helps, I don't know if that's the question. As I said, is by stabilizing the subscap doesn't move upwards. You don't use the whole subscap. You just use the 1/3 of the upper third of the tendon, not even the rest of the muscle posteriorly. And by doing that, you stabilize your coracohumeral ligament.
I think,
Christoph, this is Dr. Samantha from Calcutta. I completely agree with Dr. Christoph because I'm doing this ASA for last probably 3.5 to 4 years. After reading and films articles, I don't repent for that because sometimes the capsulolabral complex is so weak and young guy is not for the remplissage. And ultimately at the end of 6 months to 1 year, there is no limitation of that much of external rotation which has been told in many of the literature. So I don't repent for doing the ASA. It's my opinion.
Swanendo, this is not repending because even we do arthroscopic the subscapularis augmentation. The only problem here is, as he has rightly said, 0 degree, neutral degree, 30 degree, or extra rotation position. Because if at every degree you are going to get same result, that means we are proving that original magnesium stack surgery, which was for re-riffing of the double breasting of the subscapularis tendon, was a right procedure for instability.
No, Magnuson stock is lot of double breasting, and that
Yeah.
was lot of extraordinary limitation, and also these Magnuson stock guys at the end of 10 was all over 100% nearly over arthritic. So that's why it has been abandoned. It's not for the ASA. You can compare the ASA with the Magnuson stock. I completely disagree on that point.
Okay.
Can I have a question, Dr. Christos? It's from one of our audience, from Dr. Vinay Bangera from Bangalore. Is ASA done together with Remplissage if associated with Hill-Sachs lesion with less than 20% glenoid bone loss? I think you've already told the point in your talk, but he just wants to know it again.
So as I said, the ASA pushes the head to the back, and the Remplissage pulls. So in other words, like you can use it when you have Hill-Sachs defects. And of course, you can combine these methods if you see that you have an on-track lesion even after you do your ASA. But I have to say that I haven't done any Remplissage. I've done a application of the capsule, not because it was really needed. For me, as I said, I want to sleep well. So I just did it just to reduce the volume. It was still stable. It wasn't going to the front, but just saw that the volume of the capsule was still more. So I think Remplissage would be too much to combine it sometimes. Yeah, that's why, like, maybe application of the capsule, you can do this if you see that your capsule, for example, is still too bulky, actually. But as I said, even in a Hill-Sachs defect, you don't really have to do it and to do a Remplissage. Professor Maiotti does it without Remplissage. The Manus, the Athenian group, actually they've combined it as well.
Thank you. That answers the question.
Yeah, Roshan, you have a question? Yeah, yes, Rajiv.
Yeah. So Christos, because we know in recurrent dislocation shoulder, there is a lengthening of the subscapularis. So intra-articular subscapularis, whenever you are augmenting it. So what is your position of the arm when you are tying the tape or suture? It's a neutral rotation, or you put it in an internal or external rotation?
As I said, I put it in neutral rotation. It's a neutral one. So in the beginning, I did a couple of cases by just putting in max external rotation, but I saw that I was risking my Bankart repair or my capsule repair. So I'm like, and I didn't see any difference in the results afterwards when I saw the patients. So I do it in neutral position.
Christos, is there a relationship between a capsular laxity and your tendency to do an augmentation?
Yeah, of course, because if you have a capsular laxity, and then at the end of the day, that's a Bankart repair, it's not going to be enough. We've seen that actually in all the patients that I actually mentioned as well, 33%, especially in patients that they do sports, and that's why, especially for these patients, it's a must, I think, to use an augmentation method. It doesn't have to be ASA if you don't want to do ASA, but you have to do an augmentation method anyways, yeah?
Mm-hmm. Yeah. Karthik, any more questions in the chat box?
Yeah, but just single more question, a little bit. Do you think ASA as a replacement to Latarjet, or there are two different indications? It bridges the gap between the Bankarts and Moni Bankarts.
That's a really good question, because that was actually my question in the beginning. And what I do is I've done it even 20% of anterior glenoid bone loss. And what I mostly do, just to be in the safe position, I talk with the patients. And of course, nobody wants to have his bone taken out here and putting it somewhere else. So he's going to go for this and kind of risk it, and then having a Larrazé or a bone block and stuff. Until now, I have to say, I'm really satisfied with my results, and not just my results afterwards, even intraoperatively. As I said, I do this test now myself, and I try to press the humeral head to the front. I do it, I actually do it, and it just doesn't go. And even in 20% of glenoid bone loss, and it was really, really stable. And if you do another augmentation method on top there, or application, that was the case actually, then I think you're not going to have any problem. Especially if the patient is a bit older, more than 30, for example. That was my case.
I think, Christos, this is Dr. Samantha. I think you are stressing more on the 20% job, because if it is less than 20%, then only probably we are going for the, we are all agreeing for the ASA.
Contraindication.
I didn't hear you. Sorry, I didn't hear you.
I think 20% of the glenoid bone loss, we are all agreeing that we can go with the ASA.
Yeah.
Yes.
There's one last question from audience, Dr. Vinay Bangera from Anglo. I think he's asking the same point. What is the degree of abduction you do ASA while tightening the subscap? I think you've already answered that on
40.
neutral. So.
No, the abduction is 40. Abduction is 40 degrees.
40.
Neutral rotation.
Yeah.
In bony Bankarts, is your experience with this kind of augmentation same, or do you do something different?
It's same. I use it, as I said. Now I'm a bit more, not just a bit. I'm more aggressive towards ASA. I do it to every single patient now.
Okay. Great. So I think
One
that's
last question from my side, sir. Have you tried Latarjet with ASA?
If I've tried it?
Yeah.
No.
Do you believe on that, or?
I believe on bone block with ASA. Yeah. But Latarjet with ASA, I don't know. I haven't even seen it. I haven't heard of it. I don't know if it can be done. But at the end of the day, you have to put it through the subscap tendon and then fix it as well. I don't know. It's
just a question.
No, I think that was a really challenging thing, and I think it is encouraging because the way you demonstrated the cases and the results, I think it actually increases the confidence of us, especially on a high-end athlete with recurrent instability and some amount of bone loss also, to go ahead and actually augment. And I think the results are speaking as per your series themselves. It actually increases the confidence of Indian arthroscopy surgeons to go back, revisit their results, and maybe try in certain subgroup of patients to start with arthroscopic subscapularis augmentation. I think Roshan has a final question and some comment as well. So Roshan, please.
IPS, I just want to know from Christos that usually in Latarjet, the inferior part of subscapularis is the one which acts as a internal spleen. The triple block effect, which is created, the bone effect, the scapular effect, and sling effect.
Yeah.
And in this case, we are going to use a superior part of the superior portion of the subscapularis, superior 1/3 or maybe a small piece of subscapularis to create a chakrin. How does the mechanically it is going to be the same effect, like what he has shown in one of the paper, where he has shown very high results with ASA as compared to Latarjet, because Latarjet is using the chakrin effect of the inferior subscapularis, which is a much stronger and much bigger, bulkier part of the subscap. and superior part of the subscapularis tendon is a very small part of tendon which is going to get create a check ring. So Christos, can you enlighten us on that?
Good question.
Yes. First, that's a good question, because first there's studies from Tauber from Munich, from the Athos Clinic, from the partner Frank Matterschläger, where he says, doesn't matter, you don't have to go to the inferior subscap. You can do it. It's exactly the same if you go exactly in the middle. Has shown that it doesn't matter if you go to the middle, you do your split in the middle or inferiorly. One. And the second is, what I think is just the prevention of letting the muscle or the tendon, sorry, of just moving upwards. And then the whole point of this thing is that you get a better coracohumeral ligament. That's what I think, because on the back of my head, what I have on the back of my head is, I don't know if it's going to heal there, the subscap tendon where I put it. But as long as it's there, that's going to stabilize, that's going to strengthen my coracohumeral ligament. And that is going to help for an anterior or anterior-inferior dislocation in the future. Because we all know, like, when you get older, the elasticity of your capsule gets less and less. So the time in this case is on your side. So I don't know if my construct is going to be there the whole time, but as long as it's going to be there, I know I'm going to get a better coracohumeral ligament that's not going to allow a dislocation. And second, the capsule is going to get anyway stiffer.
Yeah, definitely it helps. Thank you, Christos. I think no more questions in the chat box. Wonderful presentation. Thank you for enlightening us on this interesting topic. And I think we'll go back and revisit all our cases, and in select group of patients, really try to follow your surgical steps to improve our patient outcome. Christos, thank you for joining in. Indian Arthroscopy Society is really obliged for you to have spent time with all of us. Friends, wonderful work today, and I think this presentation was really an eye-opening. Do join in tomorrow at 7 p.m. on 5th December for our yet another webinar. And this is a combination of cuff tear with instability, a different ball game. Dr. Bhuvan Machani, he's consultant orthopedic upper extremity surgeon in Dubai, in Burjil Hospital, Dubai, UAE. He's going to talk about cuff tear along with instability. I think it's a combination of tear and instability where we still have a dilemma, and this webinar definitely would help us in sorting out this dilemma. Do join in tomorrow on 5th December at 7 p.m. Indian time for this wonderful meeting. Thank you very much, Christos. Thank you for joining in and making all of us more informative and more wiser today evening.